First of all, let me thank you to participate in this webinar that Transform Europe is hosting in the framework of Transformadora, the World Social Forum Transformative Economies event that we should have in the normal form in Barcelona in these days, but unfortunately with the COVID, we translated in online webinars. As you may know, Transform is since many years from now hosting this discussion on the commons as a political subjectivity of transformation. And I'm glad to include also the social cluster in the commons, since we are used to have the aspect of the commons are very different with the natural and the digital form, but not this area is not very well integrated in this discussion. So I'm glad to have Francine with us that is helping to, first of all, to introduce this argument in Transform Working Group, but also to host this webinar in order to go deeper. And since we are used to live in this condition, of course, we will ask you also to give us a sort of overview of what is your condition in your country with this situation. But saying this, I'll give you straight away the word to Francine. And I think that we, at the end, will introduce also the second webinar that we lost in the second part of this day. Francine, the floor is yours. You mute, open the microphone.
Sure. Okay. Yeah, good afternoon, everyone, and good evening for our Indian friend. I think it is very important to stress that for us, commons are really a crucial element for social change and for political change and for economic change. And that is the way in which we see it, and that is the way we are working with this concept. And what is important in this specific context of the health crisis is that we are reminded of the fact that usually it is said that commons go beyond states and markets, which is right, and we agree with that. But we also say that they do not go without states and markets. And I think that in this health crisis, this is a very important element. And at any rate, if we talk about social commons, and I hope to say a couple of words more on it after your interventions, this is for us a part of a global process of a just transition and systemic change of the paradigm in our societies. The crisis today is multidimensional. This is very easy to say, but it is important to, again, to focus on the fact that today everyone is aware of the importance of healthcare. And from there, from the healthcare, we go to social protection, because you cannot have healthcare if you do not have the crucial elements of social protection, whether it is income security, whether it is pensions, whether it is all the other elements that come usually and normally with social protection. Also, what is constantly repeated is that every crisis is an opportunity, which is, again, which is true, and that's something that we accept. But for us, it is an opportunity precisely to promote this concept of social commons, because what it allows us to do is to make all the different interlinkages from healthcare to social protection to the environment, because you cannot have a preventive health system if you do not tackle the multinationals, if you do not tackle the toxic residues in our food, if you do not tackle all the corporations that are contaminating our air, our soil, and our water. So for us, it is a possibility to make these interlinkages and say, look, we are working for the environment. We do it by starting from the social elements of social policies. And this is more or less the framework in which we are working. If there is time left, I can say a couple of words more on it at the end of your interventions. But the main thing is indeed that we can make the link between social policies and environmental policies. And that is what it is about in this whole Transformadora exercise. Now, I will straight away give the floor to our speakers. We will be slightly changing the order. We would like to start with Gaëlle Grigorian because she will have to leave early, as I understood. And Gaëlle is head of policy of the access campaign at Médecins Sans Frontières, Doctors Without Borders. She has a PhD in sociology. Her research concerns are social movements, globalization, health and technology. She has worked in European Parliament and is the author of several articles on commons and intellectual property. So Gaëlle, the floor is yours, please.
Thank you very much, Francine, and thanks for accommodating with my my schedule of today. I'm sorry I was not aware that I had another meeting at 4, and I will have to leave the workshop, unfortunately. So I'm the head of policy of the Access campaign of MSF, but I'm also working with Remix the Commons, French group working on the commons. So it's one of my concerns to make sure that the issue of access to health and care products meets, the thinking and the discussion we're having about the commons in so many other fields. So I wanted to start with just a comment, about the fact that I think we are all very often talking about health and healthcare as a human right, and many of us consider it is a human right. But at the same time, we see that in many places, access to it is extremely limited. Of course, from the point of view of MSF, we witness in many countries where the humanitarian organization is operating the problem. MSF delivers emergency aid in more than 70 countries now, where due to armed conflict, to epidemic, to national disaster, or different form of exclusion, we see population struggling to access healthcare. But what is new in a way is also that we see that access to health is also eroding in the wealthiest countries, where healthcare are supposed to be well established and functioning, and where population have, the habit and expectation to have access to healthcare. So, for instance, in my country, France, access to hospital care or access to specialized physicians, such as gynecologists, ophthalmologists, cardiologists, etc., or access to diagnostic tests are often delayed. In France, we had hospital staff demonstrating in the streets during more than a year before the COVID epidemic to denounce the lack of resources and the lack of capacities given to hospitals, and where we see very often doctors becoming pretty desperate because they cannot perform normally their job, and they actually realize that they are putting other people in danger because of the lack of resources, to provide healthcare. In Europe, we see that access to expensive treatment is increasingly becoming a problem, and we see rationing develop. People are put in situation where they have to wait to get access to the medicine they need, and meanwhile, their health deteriorates. We see medical guideline being twisted, to adapt to budget limitation. This is what we saw about hepatitis C already in 2013 and 2014. And since then, the problem is only becoming bigger, you know, with many different cancer treatments or treatments against rare diseases. In the US, it's becoming common to see people from the middle class having to mortgage their house to be able to pay the bill of their cancer treatment. So in this context, talking about health as a commons, I think is a way to bring back the necessity of ensuring this right, of actually implementing it into the discussion, which means, of course, that it's a way to politicize the discussion and to force a debate about the fact that although, you know, I don't think that the state should be cleared, the states should be cleared of their responsibilities. We should all be part of this discussion about how to establish that, you know, health is ensured and how is it that health systems are governed. We as doctors, but also as patients or as, you know, future or potential patients. So to think health as a common, I think it's indeed a way to consider healthcare as a resource and to discuss how we want to organize it with all the different stakeholders, you know, and organize the governing so that healthcare, health products are available, exist, you know, in a sustainable way, but also are going to be accessible to all the people who would need them. So that's the challenge, and, you know, a challenge that is only, you know, made more obvious by the COVID crisis, but at the same time, I think it's also important to see it as a proposal or a call for, you know, a methodology about how we could do that, you know, and I will come back to that in a little bit. If we look at the COVID situation, you know, during the past several months, one thing that is being made extremely obvious is the failure of the market-based system to provide access to healthcare and health products. Of course, you know, I mean, in this crowd, when I say that, everybody probably would agree. But the problem is that it's easy to say it. The problem is the logic of healthcare, the logic of access to health products is really totally built on the idea that because there is a market, you know, having a market, making all this a market is the best chance we have to actually get the innovation we need and have access to it. And it's not easy to change that. You know, you can see very simple fact, like the fact that if you want to access a medicine in pretty much all countries, the first step is to get the marketing approval. The marketing approval is actually when the authorities are saying, this is a good product, you know, it's good for this indication, and it's not too toxic. You know, it's the result of what science has done, you know, is bring to the agency so that it established that this product should be used for that indication. And, you know, it's going to be globally good for the patients. The name of that procedure is marketing approval. So that gives you, you know, an hint about the general logic. What we see with COVID is that the market logic doesn't serve the public health logic. And I think it's interesting because it's interesting to look into the details of, you know, the cases where, you know, it's made obvious it doesn't work, because there are different scenarios. One scenario is the old products, the basic products, things that are not very, I mean, were invented a while ago, are not necessarily, are not expensive to produce, but are not available. And so we've seen that with the mask, the ventilator. We've seen that with, you know, very basic antibiotic like amoxicillin or doxycycline, very old products, you know. There is no monopolies on this product. There is no patents, but there is also no interest for many economic players to produce them because there is no big money to make out of them. So this is, you know, typically what people are going to call a market failure. Of course, the problem is that we see that there is so many different market failures, that it shows that, the logic behind the reasoning is not working, at least for the purpose of public health. So here I'm talking about the old product, but we could talk about the new product, the innovations, what we often refer as innovations. Right now on COVID, the discussion is about vaccine, how to make it so that we have one or several vaccines that are effective against this specific virus. And what we see is that there is a lot, massive, investment of public funding, but absolutely no guarantee of equitable access at the end of the process. Why not? Because there is owners' rights, IP rights, patents, monopolies in different ways, trade secrets that are going to make it possible for one or a few companies to control the products and to decide of the price. And of course, we know the logic is mostly, to sell to the best buyer, so to get the most money out of it. So in the case of COVID vaccine, we see it's made obvious that there is a massive public investment. So we could think, oh, it's a very special case, but it's actually not a special case, because when you look at the economy of pharmaceuticals, you see that there is actually very important public investments in medical R&D, and usually that is happening through many different channels, direct funding, but also, tax cuts, many ways through which this economy is actually subsidized by states. Then all this disappears somehow. Nobody really pays attention. There is owners' rights, and there are monopolies, and there are high prices, and governments complain that it's extremely difficult, if not impossible, to impose to big companies, rules to make sure that people have access. So this is really so at the two ends of the spectrum, the old product, the old but essential product, and the potential innovation, we see that the logic of the market is not working. So saying that is not necessarily going to, get Emmanuel Macron in France to all of a sudden change, the way he's governing, but at least it allows us to open up a discussion and start to discuss how else we could organize things. So in the field of health, and particularly in the field of health products, I think we need to acknowledge that trying to work with the method of the commons brings some difficulties. It's not that we cannot overcome it, but I think it's important to look at it, to realize it. Why is it so? Because on one hand we have the industrial production. So it's a matter of scale. The scale of the scale of this environment is different than if you want to organize healthcare in a community, different type of services in a specific territory and a small community. Here you do have to kind of work at the middle scale, where you need to be able to have industrial production, and you also need to be able to have some sort of large exchange of knowledge and discussion between researchers if you really want to get the best research. So this scale issue is something complex to deal with, but again, I don't think it is impossible, but it's important to acknowledge it, because it does prevent us to say we do have a very simple and easy situation to implement. So actually, when we talk about pharmaceutical tools, medical tools, it's feasible to, and it's interesting and important, I think, to develop, the discussion about how do we treat them, produce them, govern them as commons, but it's also not going to be done in one day. But again, that's why I was saying, I think it's a method that we can propose. And so if I go back to my two problems, you know, on one end, the old product, on the other end, the innovation, we see ways to at least start a discussion and organize a conversation between the different stakeholders. On the side of the innovation, the obvious entry point is mandatory sharing of knowledge and data, and the development of users' rights, you know, as opposed to intellectual rights. So doing this is not necessarily easy if you want to think about it at the global scale. But it's also, you know, not necessarily impossible. Right now, in the specific situation we are in, when you see the amount of money, the billions, because it is billions, that are being put on the table, either by you know, by Europe, by the US, by others, there should be, you know, a table around which the different stakeholders should be able to sit and discuss. How are we using this resource? What sort of research are we financing? What are the rules that we are going to use to make sure that there is access everywhere where it is needed? So transparency, equity rules should be discussed. And so when you hear Angela Merkel or Emmanuel Macron talking about global public goods or universal commons, it's frustrating actually, because we know that when they say that, they don't think about something specific. And for me, the first step would be create the political space where the stakeholders are going to discuss about how we govern those goods. Right now, what they do is they pledge money, they commit money, they will spend money. This money will go directly in the pocket of some large companies. There is absolutely no transparency and no discussion about the use of the money. So mandatory sharing of knowledge and data and science would be, you know, a way to start to organize treating vaccine against COVID as a common good. And, you know, together with the establishment of a space where the different representatives of, you know, the patients, the health workers, the researchers, the industrial components, the states, and so on, are around the table. On the other hand, there's been a lot of discussion about difficulties to access basic products and the issue of shortages or tension in regards to supply of product. Here, it's even simpler to try to develop, you know, to plan the production and the use of essential health tools as commons. What it requires is, well, first, you know, to be clear about the health needs, and that I think is what is extremely interesting in this way of working, is that instead of starting with, you know, what is it that you need to bring to the market to make money so that you can do more research to maybe bring something else to the market, because that's the way it works now. You start with what is it that we need. Amoxicillin may be a very old, or penicillin, you know, very old product. It's an essential tool from the perspective of public health. Not because you can make money about it and sell it, just because it is useful for doctors and for patients. So you start with the need. From the need, you go to, okay, you know, how can we, what do we need to produce that? For instance, right now we have this discussion in Europe. At the European Parliament, people want to fight back against shortages. So instead of putting more incentive on some companies, this should say, what is it that we have on our territory that allows the production of those essential tools? Some of the resources are public resources. Some of the resources may be, you know, small and medium enterprise, as we say, small companies. Let's map, you know, the capacity. And then how are we going to organize the production and govern it? And that's when, you need the stakeholders to, again, come around some sort of table and with a clear goal and discuss what are going to be the rules, the rules to ensure that the production is, of course, economically sustainable, but, to ensure that's what the main objective is access. So resources will be used to allow that the health tools are produced and made available to the people who need them. So this is something that could practically, start tomorrow. There is absolutely no problem, no limitation. It's only a matter of political will at this point. And it's a matter of making that sort of proposition part of the discussion instead of having what we, unfortunately, and even if people now more than before realize the level of the problems, are okay to say, okay, we are going to put some more incentives, or like with the vaccine, we will put a lot of public resources. But as some people have been, trying to explain, we're not anymore, in 1950. Just putting money is not going to be enough. What we need to discuss is the condition of the use of the money and make sure that the people are in control of this money. And to do that, you need transparency. You need to be clear about the terms and the condition. And basically, it means to totally rebalance, the relationship between the public and the private. And I believe that the method that comes with the commons and the logic of the commons is something that allows us to formulate that discussion and to have that discussion and to organize ourselves practically. So I'll stop here. Thanks.
Thank you so very much. Before I give the floor to the other speakers, and since Gaëlle will have to leave early, I would like to know whether there are questions for her, not only from the participants, but also from Dr. Hani, Dr. Amoulianidi. If you have questions or comments, I think this is the moment because Gaëlle will leave us early. And so we have at least an opportunity to have more comments and more inside knowledge from her. Any questions or comments? I have one point, Gaëlle, just it looks very, very basic. I'm not an expert in these matters, but in the end, it is about the relationship between public authorities and private companies. And you said it is a matter of political will. We can start tomorrow if we want so. I believe that is true. But at the same time, is it not also a matter of power relationships? And do public authorities really have the possibility to say, now we're going to do this and nothing else?
I believe so. I mean, the problem is that policymakers in the field of health, but more generally, have come into the habit to collaborate with the multinational pharmaceutical multinationals in such a way that they feel under a lot of pressure to derail that train. But when you look at what is actually happening, in the medical field, and if you look at medical research, there is massive investment and subsidization from the public sector, as again, in many different ways. It is our patients and our hospitals where the clinical trials are being done. It is, many grants and funding in many ways. It is, funding of the universities. It is the buying of the medicine, the reimbursing of the medicine, the tax cuts. I mean, you can pile, the pile of everything that is given to those companies is very high. So they the state agrees to do all that, you know, they do that. They could stop to do that, you know, they could stop to give all these incentive at once. On the other hand, they grant the monopolies. It's something that we often forget, you know, countries complain because the companies have the monopolies, but it is the state who is giving the monopoly to the company. You know, a monopoly, a patent is a right that works on a territory. To have your patent in Europe or in France, you need to ask the patent office in Europe or in France to grant it. And if they don't do it, you don't have it, and you have no monopolies. So it's always, you know, this weird game where I think policymakers got so used to be threatened, that's true, be threatened by the industry, benefit for some of them of, you know, collaboration with them, and also be used to just develop their work based on what the industry was saying. They consider, you know, they started to treat the representative from those companies are as experts helping them building the policies, you know, and this is not the way it should be. You know, it should be a voice among other voice helping to build policies. Okay, but so they developed themselves that dependency, you know, they lost expertise in their, you know, health cabinets and departments, and they got, you know, so used to rely on those guys, but they can stop to do that. And again, I mean, when we see, you know, right now with the vaccine, you know, the billions that Europe is giving, what are, you know, the condition of the use of this money? You know, it's a fair question to ask. Why isn't there any transparency on that? You know, why isn't there any, you know, fora where we discuss the way the money is being used? Right now we say, we need the money, it's a crisis, an emergency, and so on. The money is coming. Then you have a couple of international agencies, which, by the way, are not anymore UN bodies in most of the case. You know, there are those international agencies with a board, with a couple of representatives from a couple of countries, from a couple of maybe UN bodies, from the Gates Foundation, from a couple of companies. It's this little board that is governing this international institution, but there is no member states, you know, it's not the functioning of the UN institutions. And those different players, CEPI, Gavi, Global Fund, UNITAID, and so on, are all there saying, we know how to do our job. I take care of the supply, I take care of the R&D, I take care of this and that, give me the money, I know how to do it. So, and problem solved, you know. They will then give the money to the companies. There is no, you know, it's not, I mean, there is absolutely no collective governing and no transparency. So when we give the money, we could set the conditions and very clearly, although it always seemed to be a bit of a, you know, obvious thing, having transparency is something that we absolutely don't have at this moment, and it is unacceptable, you know. But it's also interesting to see that, you know, at the European level, for instance, you know, right now there is a initiative report being discussed about shortages in Europe. And of course, you know, I do find always my allies, you know, among the Greens and, you know, some of the SNDs sometimes. But right now I see also people from the PP, the right-wing party, you know, some people saying there is a problem. We do need transparency. We need to know what we get for all this public money. Maybe we need to, you know, lift the patents in some case because this is impossible. So there is some kind of better understanding of the severity of the situation and the need to rebalance. But to rebalance, that's why I think talking about health as a commons is important, because it's not going to be done just by, you know, you cannot just count on the state to do that. We need the people to be part of the discussion. We need the doctors, the patients, and so on to be there, you know, because otherwise I don't think it's going to happen.
Thank you so very much. Are there any other questions or comments? No? In that case, we thank Gaëlle very, very much for her presence here, for her contribution, which was really very, very useful. And I would like to give the floor then to Dr. Hadi Seirak, or apologies because you had to wait. You were supposed to be the first speaker. Dr. Hadi Seirak is physician and a public health researcher. He used to be global coordinator of the People's Health Movement, and he's based in Cairo. He has been working in many research projects, educational and training activities, always in the field of public and global health. So please, Dr. Hani, the floor is yours.
Thank you very much, Francine. I will take quickly about the COVID-19 and focusing a little bit on health system policies. It's quite a difficult time everywhere. Actually, my home country is Egypt. But currently I work for at least for a while in the US, and I'm now in Texas. When we witness huge surge of COVID-19 here, and this is quite interesting time, and most likely, or at least these are the expectations, Texas is going to be the second New York. So it moves in a very, very quick way in this direction, and no willingness to stop that. And I think that it's a very well-informed decision to leave it as is, and this is going to discuss a little bit in this presentation why. So to start here with very quick trends, we have right now more than 10 million cases. It's 10,400,000 and something this morning or this afternoon in Europe. And it is increasing. And in some places, it is increasing quite dramatically. If you look at the curves here, in United States and Brazil, India, Bangladesh. So it is the North America, Latin America, and South Asian countries. It is increasing and increasing rapidly, and added to this, the Middle East as well. And a good example of this is Egypt. And it's declining in Europe, but not equally among countries. So while it's quite good in Greece, Belgium is doing a good job, and UK still not in the same better. And in many countries also, after what they call it, reopen the economy, we witnessed quite a quick increase in number of cases. The good news is, which is not very well explained till now, is mortality rates are less. And this is common phenomena, and some people are talking about the change in treatment protocols. Some people are talking about changing the virus itself and so on, but it's not very well studied yet. But at least it's good news. What did we learn from that? We learned that while it's bad, it's a huge threat to public health, to people's lives and everybody, but the impact is not equitable. So it's not really bad for everybody. And this is not new. Even wars, we learned that wars are not bad for everybody because there are people are making lots of profits out of it. So actually it's very good for some people to promote the wars and to have more conflicts and so on. And the same here. The pandemic is not bad for everybody, even if it kills considerable number of people, and we'll go for that. Also, we witnessed the failure in the current structure of global governance for health. And this was pretty covered in the first speech, but we'll touch upon it a little bit here. We also witnessed failure in health systems to provide adequate response to COVID-19 pandemic. And there was lack or absence in some places of social production. This is nothing new in that, but the severity of the pandemic exposed these elements to great extent. Starting here with inequitable impact. In the US alone, while 40,000 people, 40.7 million people lost their jobs directly due to COVID-19, we had 2 people in the world, they made around $63 billion profits in 10 weeks. So for these 2 people and some other more, not a lot, it's good. It's not bad at all. They're not complaining. And generally for the US billionaires, wealth increases by 485 billion. And this is 16.5% increase from what it can be if it's normal condition. So again, here, the pandemic was quite good. And these 2 guys, it's not a secret, these 2 guys are the CEO of Amazon and CEO of Facebook. They made $63 billion. Again, if you look here, who is most impacted by the pandemic, you'll find clearly that African Americans in US are most impacted. And this is not only in number of cases, but also deaths. So more of them are, they die when they get the infection, and you will find that whites are the least impacted. And why is that? Because people of color who are working in the most dangerous works, and actually they are serving us. So if you look here, about 75% of healthcare workers are women, and a very good portion of those who are in front line are people with color. At least in the US, this is the case. And also those who are most impacted, who are coming from low-income households. So nothing different from the pattern of infectious diseases and serious illnesses all over the globe and history. So why it is failure of the global governance right now? We have a leadership crisis, and the leadership crisis here is not only from those who are leading the big institutes like World Health Organization, but also within member states. We found the withdrawal of the US from WHO, and despite the fact that I'm in the US right now, but I think this is very healthy. And the main challenge here is not to get US back to fund US, to fund the WHO, or to be a part of its governance. Actually, it would be a great relief as US is withdrawn from the global health governance, because they've been practicing their power a lot. But who's going to fund the WHO? Will other member states take responsibility to do it or not? Will people make pressure to have reasonably funded global international organization that's able to do its work or not. So this is the main challenge right now. Lots of people are talking about Trump cuts funds from WHO, and this is not true. We witnessed that during Obama's administration, the US administration cuts its funds for UNESCO when UNESCO dared to recognize Palestine as observer in UNESCO. So it's not Trump. It happened during Obama's era. It is the big power. And this raises a big question about what are member states. When we talk about member states, even in WHO, do we have real democracy? And talking about US specifically, or it became very well-established plutocracy. So in this case, the idea of having member states representing people, it's not true. So talking about Europe, it is still the welfare state, it is still the democracy we are dreaming of, or became plutocracy, complete plutocracy. So these governments are representing certain interests and they cannot do outside that. And simply the whole political system around the idea of election doesn't work, at least from my point of view. And it needs to be reformed in a different way that allow not just election. Democracy is not just election, which is manipulated to a great extent here in the US. If somebody does not have media like Fox News, will not make it to the elections, full stop. So it's like that. And I think this is almost everywhere. We found a huge failure of WHO when Costa Rica provided, and maybe my colleague, my friend Amelia will talk about that, when Costa Rica tried to make a proposal for a public patent for COVID-19. It was refused. So it will not go through. So still, there is huge protection of interest of making money out of people's illnesses and out of people's pains. And nobody cares about that. The use of the term reopen the economy, and I see this became a very big manipulation of people, like if we do not open what they call it economy, people will fall hunger. So the hunger will increase. They will not find food. They cannot work, as if this is the only definition of economy. No, we don't need this economy. Don't open this economy. Let's rediscuss what is economy. If this is the only model that we can live with, so it became like, okay, it's you die from unemployment or from hunger or die from COVID-19, and people can choose. And these choices have been given to people in a very frank and concrete ways, especially in a country like the US here. And it became a dominant culture, like people are actually asking for the state to open and stop the stay-at-home orders because they want to make money, as if this is the only way that people can live with because they do not have any other choice. The failure of health system, we have absence of preparedness plans at different levels, global, national, and local levels. And to some extent, because this is quite new, this is unprecedented. So in many cases, there were small-scale epidemics in certain places in the world and mostly in the poor countries, and that's okay. We can just close these countries and let some people die till pandemic ends. And this is like the case of Ebola, for example. So, and that's why Ebola have been there since 60s, but there is no vaccine for it because it did not affect the rich. We have weak surveillance and monitoring system, and till now, and I can talk very confidently about the US, the surveillance system is so weak. There is no capacity to monitor even positive cases with COVID-19. There is no way to go beyond the direct testing. And the numbers till now are representing what we can test. And actually, the US is not doing much better than other countries. When Trump said we need to reduce the testing, we need to slow down because it gives us a bad face. So, and he said it very frankly, when we increase number of tests, we get more cases. So the US appear bad. So we need to slow down. Don't test people. Let them die. And this happens in Egypt. And this is the problem in the two countries I'm affiliated with. It happens exactly in Egypt. They slow down the testing. They don't want new cases because the regime wants to show that we are on top of it and we are managing very well. We have a shortage of healthcare workers, and there was in the news, there was talk about increasing the number of physicians and nurses in the UK recently from outside, and the big question is where from? And this is a very legitimate question. So we're going to increase number of physicians and nurses and healthcare personnel in the north. Where they're coming from? And what's going to happen in this country? They will leave. And on the other hand, health workers who are working in the global south with no protection, the mortality rate in physicians and nurses in Egypt, for example, is so high. Physicians and nurses are dying from COVID-19 because simply it's not only they are not protected enough because lack of resources to get them the protective clothes, but also because when they get infected, they cannot find places. They cannot find hospitals themselves or ICUs to be in, and they are healthcare workers. So many of them are dying because they cannot find places to be in, but they have to continue serving patients. So what shapes the response? And here I would like to discuss 5 elements. One of them is the fear of uncontrollable spread. So in the beginning, there was a huge rush to try to control the pandemic, especially in places like Europe by lockdown. We need to control it because we don't want this to be completely out of control, and because it was realized that it affects the poor and the rich. Same level. But we see right now with time, it's not the case anymore. So the idea here became, okay, we know how it happens, and we know that it does not affect people equally, and we can reopen gradually or rapidly. It depends on the country, and we have means to protect the elites. And I think at least in the US, this message has been very, very clear. We will not close. We will leave it as is. We need people to go restaurants. Some restaurants here in Houston, where I'm living very nearby, are giving incentives to people to go there. There is no regulations. The 50% of occupancy in the restaurants is not very well respected. People refuse to have masks because the messages are being given by media is very confusing. And this is the second one, people's awareness and media messages. The media is not talking to people to let them protect themselves or to wear masks. They say everything is under control, we're doing fine, and we are ready to open. And this means we're good. So the day they said we are good and they started to open here, it happened in Texas, you found people as if they are in a public holiday and they are celebrating it. So the cases started to rise very, very significantly. The economic impact, and again, this will take us to what's economy. What type of economy we are talking about. So if we are talking about market-driven economy, yes, it's affected, and it will continue to be affected by pandemics because it depends on consumerism. So if we stop consuming the products and we have a phenomenon of overproduction all over the world, so there is no markets. But if we talk about some different economy, it will not be affected the same way at all. The global governance, and I think we talked about this a little bit, and I would say I'm not a big believer in getting stakeholders together in a political place. It solves the problem, because when we get these together, we get them together with power dynamics. So the idea here, if we get the corporates with politicians and some others, people are not represented in this political space in all cases. So I think it's a way more than just to get together to discuss solutions. And there is no way to get a solution that is win-win for everybody. Like negotiating with big corporates, pharmaceutical companies, for example, to have vaccines, to have universal access to vaccine. I don't see this as a very legitimate discussion. I prefer that countries just use compulsory license to make the vaccines and medicines, because negotiating with companies, it comes with power structure, and it's not going to work. But the use of also flexibility of TRIPS and something like compulsory license will not happen, because the government is not going to do it, because they are affiliated with the corporates to great extent. So what is the solution? And I will not talk a lot about here, but for me, and for People's Health Movement, which I'm honored to be a part of it, is getting back to the principles of Alma-Ata Declaration and implement primary health care as articulated in the Declaration of Alma-Ata, and get completely away from the talk about coverage. We do not need coverage, we need universal health care that adopt the principles of Alma-Ata. We talk about preventive, curative, rehabilitative, and promotive items, and before all of that, it's a human right. This means it's unnegotiable. So when we're talking about right to healthcare, right to access to medicine, and so on, we're not talking about affordability, we're not talking about cheap, we're talking about full access. How to do that? To have the production in public domain. And I think unless we have the discussion at this level, it's not going to be solved. We will be all the time in the middle, trying to reach somewhere in the middle, and we cannot really go to the middle, because one side is more powerful. So the corporate side will continue to be able to pull it in its direction. So we will not get in the middle. This middle became moving. If we continue, consider the what's called diplomacy as the way to discuss, and we witnessed that lately, the change happened in the street, and we cannot forget what happened in the Middle East, what happened in France, the Yellow Jackets, and so on. And I believe strongly that parliaments and diplomacy is not going to solve it, and what's going to solve it is get people to have the power again. A change from street, not from elections.
Thank you, Dr. Hadi.
Yes.
Is it possible to wrap up because the time is running? Thank you.
Yes, thank you very much, Francine. So just very quickly saying People's Health Movement is very keen to start at country level to support activism at national and local level rather than engaging in political debates, and also proactively debate at a global level and get people to be clear about these negotiations are at global level are actually affecting people who are in local communities, and building capacity for health activism and for activism in general. We see that this is the way forward. Thank you very much, and sorry for taking more than needed. Thank you.
Thank you so very much. Thank you. Sorry. Thank you so very much, and sorry for having to interrupt you. But time is running, as you know, and your talk is so very interesting, and we all keep listening, and then we forget to look at the clock. So we will have some time left for questions and answers, but I want to give the floor now to Dr. Amulya Needy, who is a public health expert working to bring existing public health services to the poor and vulnerable patients. And he works mainly in India, in the rural hinterland of the state of Madhya Pradesh. And he is also the national co-convener of the People's Health Movement in India. Dr. Amulya, you have the floor. We don't hear you. We don't hear you. You have to unmute.
Yeah. I'm audible now? Yeah.
Yeah,
so
right. Thank you.
For the whole discussion and all the approaches and strategy where we work, and because as we are part of the same movement, so most of the things Ani has already covered, which the background things. So basically I'm in activism from last 20 years and basically working on unorganized workers and a disease called silicosis. It's the workers works in the mines and they get exposed to this disease called silicosis. And we are struggling with this policy and the legal advocacy, that aspect. And other aspect is my main work is unethical clinical trials are happening in India. And from last 10 years, I'm fighting with this, also mobilizing the campaign around this unethical clinical trials, as well as judicial activism. We have filed a public interest litigation in the highest apex court of India. So in context with COVID, I'm going to talk a little bit about the India and then Kerala experience, because this Kerala is one of the state in India, in the southern state, and which try to overcome this pandemic situation. What are the various strategies? So basically, if you see India is a big country. We have a 1.33 billion population, and it's like many states around. We have 37 states in India, and all states and central government, they work collectively as well as independently also. So many states also respond differently. They use various different strategies. The central government use various larger strategies. The background, if you see the country when the pandemic initiated in India, and there were lots of discussions was going on. So the whole issue was India actually was delay in response. The central government was delay in response. And if you see the lockdown, within 4 hours, the lockdown was imposed in the country big country like India. And you may have seen in the media report, lots of migrants were walking in the roads and they were traveling hundreds of kilometers walking, and there was low transport and facilities. So that was the whole situation. And then also we know what is the public health system in India. It's a weak public health system. And also the private sector is also largely unregulated. So in this situation, we try to respond this pandemic. And it is also, if you see this, Hani has already covered about the social determinants, because I talked about universal healthcare as PHM, we always talk, but we also link with this, the whole social determinants, which we feel it is very important. And this last few months, we experience why some of the states perform well, some of the states not able to perform well. It is all due to your whole strategies, your whole governance system, and as well as your whole historical development. Health for all, we are demanding from last 20 years, PHM is already demanding health for all and integrations, and not only in India, but Asia and other countries also. Universally, we are talking about social determinants in series of our statements and our dialogues with the government. We try to build, but the reality still is there. There is a scarcity of food security. There is a whole question about the social protections. If you see the whole migrant, there is a whole challenge with this unemployment rate. Lots of millions of people have lost their jobs. And also, if you see the social protection issues were very lacking in the country, and weak public health system. In that situation, we try to respond. What the government did, they announced some social security package for the 3 months, some small rations and some food items to the migrants and some of the things. That was still very less. But of course, there was, if you see what's happening pre-pandemic situation in the month of February, the whole approach, the government, the Niti Aayog, which is one of the planning commission of India, they try to build up a policy and try to develop a model to take over the all district hospital, the public hospital, and across the country as a public-private partnership model, PPP model. It was, again, lots of advocacy was there as PHM and all. We oppose in various states and also. But you can see this was the strategy of the government. And what we have seen last few months, though, rather than strengthening its own public health system, largely India was dependent in many states on the, especially in Madhya Pradesh, where I belongs to, and I work with grassroots movements and grassroots, lots of activists and all. What we see are dependent upon few private sectors. And still it's like as and when, and you also seen what's happening in the initial, because the frontline workers, they don't have PPE kits. That was the issue. Also, if you see lots of manpower, we have less manpower. The frontline workers don't have securities. Many, if you see what's happening to ventilators and the infrastructure purchasing, still there is no transparency in purchasing of lots of health infrastructures. But in that situation, if you see in the time of pandemic, you can't develop the whole system in a month or 2 months. It's all the historical bit. And what we've seen in this aspect, because though Kerala, we don't say Kerala is a model, we say it's also part of country. So what Kerala tried to did in this whole larger state, Madhya Pradesh was, we are struggling. If you see the testing rates, see the global testing rates, we are around 6,238 per million. If you see the other 5 country, you see test rate is more than 100,000. So that is the basics. So we are not able to do the sufficient number of tests. So this is the main thing why the number of cases was earlier, it was like lacking and less. So that was the main study. What Kerala tried to do in this aspect, and we are struggling with the new labs, and one of the highest body of India is called ICMR, Indian Council for Medical Research. They were trying every day, they're trying to develop more and more labs to do the test. We are also still not able to have sufficient testing kits. So this was the lots of purchasing happening. So what Kerala did the whole testing things. They started with the whole strategy with the routine strategies, and as well as they also sentinel surveillance. but in the group of places where they go to the restaurants, they go to all the common places where people have, or medical shops or hospitals, non-COVID healthcare providers, and they were collecting also representative samples of maybe 900 to 1,000 samples per week. And they also try to see where the pandemic has increased. The other issue was, though the central government had delayed in response, in many states were late in respond to this pandemic. Kerala, the first case in India was found in Kerala. So what Kerala did, Kerala started its first advisory on 10 days before the first case, 20th January. Kerala has started its first advisory on COVID. So then we found 30th January, the first case. What they did, they also did the surveillance of all the person from Kerala who were staying in Wuhan. They tried to collect the list of the individuals. They also tried to did the whole, from the airport, anybody is coming. So they were the surveillance officer, they were receiving the patients, and then they started the quarantine facilities. Around today, around 2 lakhs people are in the quarantine facility in the Kerala. Then what they did, they tried to make various laboratories. They immediately started the testing facility. They immediately starting the COVID hospitals. And then they tried to also revise the guidelines and various. Now Kerala has around, it's a very small state, but they have sufficient number of testing labs, the sufficient numbers of tests they are able to do it. And the most important thing which they try to do, I think in India, Kerala, they have a state experts board, they have a state medical board, and they have a rapid response team. So this 3-tier structure really helped Kerala. The other aspect, which is very important, I don't feel that in India, any of the state chief ministers were doing everyday meeting. In Kerala, every day, 9 p.m. to 11 p.m. in the evening, chief minister was doing meeting with all the experts committees every day. So one of the main leader of the state is doing a meeting with all the stakeholders and every day. And you have they bring the stakeholders with experts, public health experts, scientists. You have a critical care medicines. You have a emergency medicine, palliative cares, epidemiologist, infectious disease specialist, virologists. So they try to bring everyone together, and this committee was actually giving response to the state. So they were in every day, this committee, one of our national co-convener of PHM India, Dr. B. Iqbal, he was actually heading this expert committee. And that's our other member of Dr. Rakhal Gaitonde. He was also a PHM activist who was also part of this committee. So actually this approach experiences, they allow the various experts to every day share their experience, and also all the bureaucrats, those who are dealing and medical association, they were presenting in front of the chief minister and they were taking action. So this is, I think this is a very important thing where the political leader is taking everyday actions on these committees. The second thing which Kerala worked out, it's also learning from various states. For example, if any other states is doing something good, so they were learning. So it was a learning approach. So we are not able to learn from maybe other countries what Cuba has done and what Spain is able to manage and why Cuba is doing. So there are lots of intra-country within the India, there are in the interstate learnings, but many states were not able to do this. So Kerala, of course, it's a left-leaning state, and also it's not an issue of your whole this ideology also, and all your approach actually proved. So the second part, which is very important, if you see the historical part. So from the historical, Kerala has built its own infrastructure, its own planning on decentralized model of planning. They have a rule in India, they have a panchayat. The panchayat is local self governance, and 30 to 40% funds, the whole finance goes to the local self-government in Kerala. And this is the build, it's developed the people's planning exercise, the community involvement. So there was a whole debate about social distancing and all that. So Kerala, we give a model, we are not talking about social distancing, we are talking about physical distancing and social solidarity. this is the time we have to build the social solidarity. You can't say this is, otherwise without developing a social solidarity and having, we are not able to move on with this pandemic. So this actually, Kerala tried to this whole decentralized models, the community involvement was very high, contract tracing, quarantines, and then the awareness level. You have seen in the media reports, there are lots of fake news. Hani has already mentioned about fake news, lots of media reports, which is non-scientific. There are many unregulated private sector. They were claiming that they have developed some medicines. Somebody is telling they have overcome some medicines, but Kerala actually spent their whole time in trainings, awareness, large number of information sharing, and also the transparent system. The transparency is there, so you can have this whole go to the Google and Kerala website. You can get this information and health bulletins where you can have this information every day. What's happening to various districts? How many people are in the quarantine? How many all the things? And it's like a composite trainings they have started with the doctors and the primary health care level staff. And that was a very important aspect which Kerala tried to do. They also have a trained palliative care staff in the panchayats. So that's really helped. And then you might have seen what's happening in India. If you see, Kerala is in the southern part, but if you see the western part, especially Maharashtra called Mumbai, where in India there are highest number of cases is in Maharashtra. If you see Gujarat, which is also, there are number of highest where the Prime Minister belongs to the state of Gujarat. So what's happening, the state where a larger number of cases, so there also, what are the learnings they try to learn, and also we try to understand what's happening, what are the best strategies they are using from this part. So that's also very important to have, to develop understanding what's happening, how they break the chains, what's happens to the, because if you see many in Mumbai, there was a issues that lots of patients were not able to get the beds, sufficient number of beds. The private sector were not able, the charges of the private sector was very high. So that was the whole debate, how you control this. In Madhya Pradesh, we try to develop a takeover of all the private sector. The Kerala, Dr. B. Iqbal, who was leading to Kerala, has asked us to give us the information, what we did, and they immediately changed. They immediately learned from this experience and they changed there. We have in Kerala, they also try to have a community kitchens. So every day there is a community kitchens for the workers, those who are alone. And also everyone is coming from outside. There is a continuous home quarantine, very strong quarantines. They have a volunteers. They have a large number of social capitalists. They have a political movements. They have a science movements. They have a youth organizations. So the culture of movements actually helped. You also have in the media reporting in Mumbai, one of the largest slum of Mumbai called Dharavi slum. It is very packed and people don't have this permanent structure to live. In many of the urban population, if you see in India, in especially Delhi and Mumbai, the people don't have. So it is very difficult to advise them to go for a home quarantine because you have a single room of 400 and 500 meters, small square feet houses. How can it's difficult? So what we try to see, what's the whole Kerala, around 80% of the population have a permanent structures. Around 80% of rural households have at least more than 3 rooms. So if you have a 3 rooms in your flat, so it's very easy to say, go to the home quarantine, but in the rural areas, if you see the large number of indigenous population is straying in, because I work with the tribals and indigenous population, they have a 1 room, small place. So it's very difficult to have a family of 5 or 6 members. So it's very difficult to advise them to go in the home quarantine. But Kerala has this social capital. So this really helped a lot. And also they have seen the community volunteers, the participations, and as well as the political leaders is doing meeting every day. This really helps. And this is the social and economic impact. They have also seen the Nipah virus. They have also learned, take over from this. And so they are also still today learning. So this is the systematic which is Kerala happening. If you see country like India, what we are, the PHM is demanding, all our statements, our discussions in the medias and all that, we are demanding to strengthen the public health system. But still today government, if you see, the India has a very big insurance model. It's universal health coverage. Already Hani talked about that. We believe in universal health care, not coverage part. But the larger program in India called Ayushman Bharat, that is called a big larger, it's an insurance kind of model. We have seen that in COVID pandemic, it failed. Because insurance model and this whole dependency on the private sector is really failed in India. Because unless until the state where there was the public health system was weak, they are not able to respond. In a state like Bihar, it is in the northern part, which is one of the weak state and poor state we see, it is not able to respond because they were not able to do the tests, because they don't have that capacities, they don't have the infrastructures. Kerala had, so they will try to manage it. So this is actually workout. But if you see this larger part in the insurance model are actually not worked out. Especially we are demanding about strengthening more investment in the public system. Still we are less investment. We are in the process of purchasing oxygen cylinders and ventilators and PPE kits, the whole kiosk. The whole first month has gone in trying to provide lots of personal protection kits for the frontline workers. Now we are able to provide to some extent, but still the infrastructure is still, and also build the whole confidence of the people. So that's why these cases, number of cases, lots of earlier also, because in India, lots of things happens earlier also. If you see, there are lots of unscientific approach to deal with this pandemic also. It's very, many media reports you can see that's what's happening. But this is the thing which I want to say. The unemployment rate has increased, migrant, the social protection was challenged. In between what India did, which many activists, as an activist, we are very unhappy and we are struggling with this in the lockdown time. They tried to change the whole labor laws. Most of India, 70% are unorganized labor. They are not under any social protections, but they changed the entire 80 years and 100 years of old, strong labor laws with the trade unions, and they were fighting to keep this alive. They've changed the entire labor law. They are now in the process of changing this environmental laws. They were trying to change into all the environment protection, lots of changes which monitors this whole environmental mines and all that. They are in the process of doing it. So the trade unions and they're struggling for this, the social security, the working hours have changed, this all acts, various act, which is very important for that. The trade unions act has been changed, the labor codes has been changed, the contract labor act has been changed. So this was the social protection from a several years of struggle. We have found this, and in the lockdown, government has used this opportunity to actually weaken the social security part. And without that, it is very difficult to respond to the pandemic, though it is coming. And it's also, it's a politically, it's a multivarious state, has a various political leadership. So we are not able to make it there are good examples, positive examples, but there are challenges. We are facing challenges to how to manage with unregulated private sector. Government, some of the states are highly dependent on the private sector, which is, we don't feel. So it's a challenge to strengthen the whole approach of public health system, how to bring out the universal health care, and as well as to reach out the health for all goal with the right to health perspective, not only healthcare, but health perspective. So this is the thing we are in this state. So thank you for inviting me, and we can talk. Yeah.
Thank you so very much. This was really, really interesting. And I think the most interesting bit for us is that everything you were telling about Kerala is everything that is in the neoliberal discourse called the old-fashioned planning, old-fashioned public authorities doing, old-fashioned statistics, education activities, and so on. And that this precisely at this moment has been so important and so crucial help people is really very interesting for us. And I do hope that the rest of India and the rest of the world, for as a matter of fact, can learn from this, because this is so very crucial. And also what you said, and this is very important for our whole social commons approach, the importance of the social capital, the importance of the work with the grassroots. And that is, I think, the main message we should learn from Kerala and from this experience. So thank you very, very much for this very interesting approach. I do not know whether there are questions, Tatiana, if there are questions from our participants. We have a couple of minutes left.
No, not really.
I have one brief question for Dr. Hani, very brief, because we only have a couple of minutes. It was so very interesting also that you said we do not have to expect too much from our parliaments. We have to look at social activism and see what can come from that side. On the other hand, you're focused on the importance of global responses. Do you see a possibility of having this social activism able to get answers from the global level?
Thank you. This is very important, Francine. Yes, it can be, because the ultimate goal of activism is to get back governments to be representing people and to take its responsibility to reshape the global governance in general. So, like, people are talking about, if you talk to anybody at WHO, they say, WHO, what we are talking about, just the secretariat. WHO is member states. So go back and fight in your own country and get your representative to influence the decision making. Okay, this is what needs to happen. So unless we have this kind of social activism at country level, but connected globally in a way that there is real social solidarity among people in different places, the change will not happen. And we see, I cannot get away from the example in the Arab Spring and in the Middle East in two ways. One of them is it was like a series when one country started and showed a level of success for a change. It happened subsequently in other countries, but also when really change happened, we witnessed a huge wave of resistance from neoliberalism, and they used what we call the contracted agents, even in the region like Saudi Arabia, like Arab Emirates and others, to defeat the revolutions and the Arab Spring and to get back to the zero square and support the military regimes once again in the whole region. So yes, we saw that this works, but also we saw that it's not easy because the North in general and neoliberalism is so afraid of it changing the modalities and get the change from activism. They like the idea of it changing by election, which is very under control, which is very influenced by media, and at the end, and here we're in the US, you know, we turn something like this to elect, and you don't know what happens behind that. So it's like, it's good to practice the right to go and play with a little device, but you don't know really what happens beyond this device. And the system in the US, what's called democracy, came with Trump. So this guy was elected by nearly 50% of voters. So if there is any system can elect this guy, this system is a failure. So I do not believe that there is no chance for this kind of a system, election-based system to work. And I believe so much in social activism and the connectivity among activisms in different countries to make a change. If we succeeded to do this, the global governance will change by itself. So we need global solidarity, not just in the South, but between South and North, between people generally all over the globe to make a change. And the pandemic is a very good time to discuss that, because people will be left to die, people will be left without vaccines and medicines, and we are learning now that there is a huge resistance to defeat this pandemic, and there is a huge movement right now to distribute the cost. There is a cost associated with the pandemic. The question now, who's going to pay the bill? Corporates or people? And the decision is taken that people will pay it even if they pay it from their lives.
Thank you so much indeed. Thank you very much. So I thank both of you, and Gail, who has left. I thank both of you very, very much for these very interesting contributions. I think we have to learn a lot. We can learn a lot from everything that you have said. I will give the floor back to Roberto to introduce the next webinar that we will be having very, very soon.
Yes, thanks, Francine. Thanks to Amulaya and Hani, Dr. Hani, and thanks to Gail that she left already. And thanks to you, Francine, and to Tatiana that is managing in a hidden way the meeting. And as Francine already said, we are now hosting the next webinar that will be focusing on just transition and commons strategy. So we close now this meeting, and we hope to see you again in our webpage and Facebook page to follow the next. Thanks to you, Dario Azzellini, and Birgit Daiber will be the moderator of the next webinar. Thanks again. And as you may see, we will have a lot of things to do. Unfortunately, we cannot talk physically and we cannot meet each other, but
one day.
It will happen. It will happen someday. Thanks again.
We have your addresses. We will find you.
Yeah.
Thanks again.
Thank you so very much.
Thanks again.
Okay.
Ciao.
Bye.